Welcome to the audio digest of the American Journal of Psychiatry. This is Michael Roy with highlights of our February 2011 issue. Featured this month, a review of severe mood dysregulation and bipolar disorder in children, a longitudinal study of cortical development in children with varying degrees of hyperactivity. Cortical measurements were also examined in a prospective study of adults being treated for alcohol dependence to see if gray matter volume was related to the time until relapse. A schizophrenia study features a comparison of mortality rates for sopranolone and olanzapine. We'll conclude by examining the use of technology to obtain real-time assessments of symptoms and substance use in schizophrenia patients. This last article has been selected as meriting CME for readers who subscribe to the AJP CME course program. Each month, brief companion exams are created for 3 of the most influential articles from the issue. By reading the articles and completing the online exam, individuals can earn up to 1 AMA PRA Category 1 credit per article. This activity is sponsored by the American Psychiatric Association. To subscribe, click on the CME link at our homepage, ajp.psychiatryonline.org. We'll begin the audio highlights with a review article by Ellen Liebenluft, Severe Mood Dysregulation, Irritability, and the Diagnostic Boundaries of Bipolar Disorder in Youths. The past decade has seen a dramatic increase in the number of children diagnosed with bipolar disorder. There's been discussion about how bipolar disorder is diagnosed in children, and one of the many questions is whether non-episodic severe irritability is a developmental presentation of mania. To help answer this question, longitudinal studies can be used to test whether children with this phenotype grow up to display classic episodic bipolar disorder. In addition, cross-sectional studies can recruit children who already display classic bipolar disorder and compare them with children who have non-episodic severe irritability. Other disorders do not accurately capture the phenotype of severe irritability. Many children with attention deficit hyperactivity disorder have temper outbursts and other problems with self-regulation, but irritability is not a central characteristic. An oppositional defiant disorder is similar, but the diagnosis is based on behavior rather than mood. For the purpose of research, a diagnosis of severe mood dysregulation has been used to represent severe persistent irritability. The diagnosis has 2 components. The first is temper outbursts that are developmentally inappropriate, frequent, and extreme. The second component is the presence of negative mood states between outbursts, such as anger or sadness. Impairments at home, in school, and with peers are also required for the diagnosis. The symptoms must cause severe impairment in at least one of these settings, and they must cause at least mild impairment in another setting. The syndrome must also be present for at least 1 year. Patients with psychosis or even brief manic or hypomanic episodes are excluded. Longitudinal, family-based, and pathophysiologic studies demonstrate important differences between severe mood dysregulation and bipolar disorder. A longitudinal study measured rates of mood episodes over more than 2 years. New episodes of mania, hypomania, or mixed symptoms occurred in only 1% of the patients with severe mood dysregulation, compared with more than 60% of those with bipolar disorder. If severe mood dysregulation is a developmental phenotype of bipolar disorder, affected children would be as likely as those with bipolar disorder to have a bipolar parent. One small study found parental bipolar disorder in 34% of the children with bipolar disorder, but in only 3% of children with severe mood dysregulation. The latter is similar to what might be expected in a community sample. Behavioral and biological measures have also been used to compare severe mood dysregulation and bipolar disorder. Both of these groups differ from healthy comparison subjects in the ability to label facial emotions, the degree of distress reported during a frustrating task, and performance on tasks that call for response reversal. However, data from functional MRI suggest that the deficits in labeling facial emotions in the 2 groups are associated with different types of neural activity in the amygdala. Children with severe mood dysregulation had less activation of the amygdala while rating fearful expressions, compared to patients with bipolar disorder, non-irritable youths with ADHD, and healthy comparison subjects. Biological differences between severe mood dysregulation and pediatric bipolar disorder were also seen in a study in which a task was rigged in order to elicit frustration. Both diagnostic groups reported more frustration than did healthy comparison subjects, but they differed in measures of event-related potentials. Those with bipolar disorder had deficient top-down executive attention, specifically during frustration. Those with severe mood dysregulation had deficits in bottom-up early attentional processes during both frustrating and non-frustrating conditions. Behavioral data and event-related potentials suggest that children and adolescents with severe mood dysregulation may have reduced attentional interference from emotional distractors compared to those with bipolar disorder or healthy comparison subjects. The extent to which interactions between emotion and attention are abnormal, and the precise nature of that abnormality, is important because these interactions may play a central role in the regulation of emotion. DSM-5 work groups considered creating a specifier for oppositional defiant disorder that focused on irritability, but instead the strategy adopted for the draft proposal of DSM-5 was to create a separate diagnosis to encompass the severe mood dysregulation phenotype. The proposed diagnosis is called temper dysregulation disorder with dysphoria. The criteria resemble those for severe mood dysregulation, with a major difference being that the proposed diagnosis doesn't require hyperarousal. The new diagnosis would appear in the mood section of DSM-5, whereas adding a specifier for severe irritability to the diagnosis of oppositional defiant disorder would locate the condition in the section for disruptive behavior disorders. Another important issue in child psychiatry is whether attention deficit hyperactivity disorder has distinct boundaries from healthy states, or whether the symptoms lie on a continuum. Philip Shaw and colleagues found support for the dimensional view by measuring cortical development in typically developing children with symptoms of hyperactivity and impulsivity. Cortical thickness increases during early childhood and eventually reaches a peak. The authors previously reported that the peak thickness of the frontotemporal cortex occurs later in children with ADHD than in those with typical development. The increase in cortical thickness is followed by a phase of cortical thinning. In the previous study, the velocity of thinning was consistently slower in the children with ADHD. The present study examined whether a slower rate of cortical thinning would be associated with hyperactive and impulsive symptoms in typically developing children. The rate of cortical thinning varied significantly with the score for hyperactive and impulsive symptoms, even with adjustment for multiple comparisons. This relationship was seen for clusters in the bilateral middle frontal gyrus, extending on the right toward the supplementary motor area and motor strip, in the medial prefrontal wall, extending toward the anterior cingulate and superior frontal gyrus, in the orbital frontal cortex, and in the right inferior frontal gyrus. More posterior regions were the right middle and inferior temporal gyrus, the parahippocampal gyrus, and the precuneus, as well as the left superior gyrus. For both the right and left prefrontal cortical regions, the rate of cortical thinning changed in a stepwise manner with the degree of symptom severity. The rate of thinning was slowest in the participants with a diagnosis of ADHD, and it increased progressively in the children with typical development. The typical group with moderate symptoms had a higher rate of thinning than the ADHD group, and the group with minimal symptoms had a higher rate than those with moderate symptoms. The asymptomatic youth had the highest rate of cortical thinning. For the posterior regions, the stepwise slowing of cortical change was less pronounced. The rates were similar in the group with ADHD and the typically developing subjects with moderate symptoms. However, the ADHD group still had a significantly slower rate of cortical thinning than the youths with minimal or no symptoms. The findings give neurobiological support to the dimensional view of ADHD. The findings appear to be specific to hyperactive and impulsive symptoms. The cortical regions, where thickness varied significantly with the score for conduct problems, were less extensive than the ones related to hyperactivity. In the right motor and supplementary motor region and the middle frontal region, growth rates were linked to the severity of both types of symptoms. However, most of the regions where cortical thinning varied significantly with the score for hyperactive and impulsive symptoms did not vary with the score for conduct problems. The difference between symptom domains is congruent with reports of distinct anomalies of brain activation and structure in children with conduct disorder and ADHD. In an editorial, Rachel Klein describes how these findings relate to the controversy about ADHD. Ambiguity of the limits between normalcy and pathology has been used to call into question the classification of psychiatric disorders, and to claim that the nomenclature erroneously medicalizes normal variations of children's behavior. It's often been argued that there's no justification for considering ADHD a disorder because it's not associated with a physical abnormality. However, the first studies of brain volume in ADHD documented that children with the disorder had significant cortical thinning and reductions of total brain volume. Longitudinal studies soon followed, showing that cortical thinning followed a developmental trajectory that differentiated children with ADHD and comparison children. Volumetric differences were replicated and extended to affected adults. Furthermore, cortical thinning was reported to be associated with a specific genetic variant, which in turn predicted a relatively favorable outcome. For the first time, genotype, clinical outcome, and cortical change were linked to the diagnosis of ADHD and its course. There was a sense of relief that research had documented brain abnormalities in ADHD. The results of previous population and twin studies have indicated that the severity of ADHD lies on a continuum. The study by Philip Shaw and colleagues is the first to link this continuum to a neurobiological abnormality. It confirms that increased motor activity and impulsivity are symptomatic expressions of brain pathology, and that the brain abnormality is developmental. Nonetheless, the differential rates of normal cortical thinning don't illuminate exactly how the brain fails to regulate impulse control and motor activity in ADHD. Nor does the study demonstrate that diagnosed ADHD is a simple quantitative difference along a continuum of underlying pathophysiology. It's not likely that a complex heterogeneous behavioral syndrome will be explained by a single neuroanatomical difference. Indeed, the authors note that alterations in cortical growth rates will be only one of the many neural changes shown to reflect or drive ADHD. Shaw and colleagues present striking data on the rate of prefrontal cortical thinning that reaffirm the evidence for a neurobiological basis of the diagnosis of ADHD, but it would be premature to use cortical thinning as a clinical biomarker. Effect size, specificity, sensitivity, and the effects of outliers need to be established. Also, there was considerable overlap in cortical thinning across the groups with different levels of symptoms. This pattern of findings indicates that we haven't reached the goal of identifying a marker for ADHD. We'll continue with brain anatomy, but now we'll look at its relationship to alcohol use. Kenneth Rando and colleagues found an association of frontal and posterior cortical gray matter volume with time to alcohol relapse in a prospective study. Alcoholism is associated with deficits of gray matter volume in frontal and other brain regions. More severe gray matter deficits have been reported in alcoholics who relapse than in those who abstain. However, it hasn't been determined whether persistent brain volume deficits in abstinence predict the subsequent time to relapse. The authors measured gray matter volumes in healthy volunteers and in a group of alcohol-dependent patients after 1 month of abstinence. Then they tracked the outcomes of the patients over 3 months. The patients were 45 men and women who were receiving 6 weeks of specialized inpatient treatment for alcohol dependence. The comparison subjects were recruited from the community and had no more than 25 alcoholic drinks per month. Each subject was scanned once with magnetic resonance imaging. The patients received the scan after 1 month of abstinence from alcohol. The follow-up period included the 3 months following the end of treatment. After treatment discharge, the patients were given appointments for 3 follow-up interviews at 14, 30, and 90 days after discharge. Alcohol use was assessed at each appointment. Urine samples were obtained to check for the alcohol metabolite, ethylglucuronide, and breath samples were also taken. Only 1 patient was lost to follow-up and wasn't included in the analyses. Relapse was classified in 2 ways, either as any alcohol use or as heavy use. For men, heavy use was defined as 5 drinks per occasion. For women, it was defined as 4 drinks per occasion. The MRI scans showed differences between the alcohol-dependent and comparison subjects in 3 regional clusters. The first was the lateral prefrontal cortex, including the right dorsolateral and inferolateral prefrontal cortex. The second was a medial frontal cluster that included the dorsal anterior cingulate gyrus, the medial and lateral superior frontal gyrus, including the supplementary and presupplementary areas, the middle frontal gyrus, and the posterior cingulate gyrus. The third was a parietal and occipital cortex cluster, including the precuneus and cuneus regions and the posterior cingulate. The volumes of the medial frontal cluster and the lateral prefrontal cluster showed negative correlations with the number of years of alcohol use and with the number of days of alcohol use during the 90 days before treatment. No significant correlations were observed between gray matter volume in the parietal occipital cluster and baseline alcohol measures. 1/4 of the patients had relapsed by 2 weeks after discharge. The relapse rate was 43% at 1 month and 68% at 3 months. Possible predictors of relapse were evaluated independently. A higher number of years of alcohol use and a greater amount of alcohol used in the 90 days before treatment were each a significant predictor of shorter time to alcohol relapse. Predictors that fell short of statistical significance included higher age and lower IQ. A shorter time to relapse was also associated with lower volumes of 2 of the gray matter clusters that were smaller in the alcohol-dependent group. the medial frontal cluster, and the parietal occipital cluster. For each volume reduction of 1 milliliter in these clusters, there was a 48% increase in the risk of earlier relapse. Smaller gray matter volume in these clusters also predicted a shorter time to the resumption of heavy drinking. Rando and colleagues used the volume of the medial frontal cluster to determine the optimal cutoff value for classifying patients who relapsed and those who didn't. This cutoff was able to classify the relapsers and non-relapsers with 80% accuracy, with a sensitivity of 93% and a specificity of 50%. The medial frontal cortical regions are involved in cognitive control with top-down processing of sensory inputs, internal states, thoughts, and actions that guide behavior in pursuit of internal goals. Greater atrophy in these regions could therefore weaken the ability of a recovering alcoholic to override strong habitual responses to environmental cues or stress. Part of the medial frontal cluster that predicted alcohol relapse is the dorsal caudal region of the anterior cingulate. This dorsal caudal region makes up the cognitive division of the anterior cingulate. Evidence suggests that it has a role in maintaining attention to relevant stimuli when distracting stimuli conflict with our goals, and that it helps inhibit incorrect actions or facilitate correct responses. Deficits in these executive functions are characteristic of poor impulse control and are known to occur with addiction. Altered impulse control has been observed in recently abstinent individuals with alcohol dependence. In this study, smaller gray matter volume in the alcohol-dependent group was also found in a region surrounding the parietal occipital sulcus and extending anteriorly into the posterior cingulate gyrus. Gray matter volume deficits have been previously observed in the parietal and occipital lobes of alcoholics who've been abstinent for up to 21 years. However, it isn't clear how dysfunction in these areas relates to alcohol use and relapse. The findings could have clinical implications. First, MRI measurement of the medial frontal and posterior parietal occipital regions could be further developed to provide neural markers of high relapse risk. Second, if validated in the future, neural markers such as these could inform treatment planning. Interventions could be prescribed early in abstinence to address brain atrophy and related function in alcoholics who are at the greatest risk of relapse. A recent preclinical study showed evidence of microglial cell proliferation and neurogenesis during recovery from chronic alcohol exposure in laboratory animals. This suggests that in alcoholics with significantly smaller gray matter volume, longer-term rehabilitation would be beneficial, both for recovery from brain atrophy and for decreasing relapse risk. Okay, now we'll take a look at our 2 schizophrenia studies. The first one was a large, simple trial designed to answer a question about the cardiac effects of ziprasidone. Does the modest increase in the QTc interval that occurs during ziprasidone treatment translate into a higher mortality rate? Brian Strom and colleagues report comparative mortality associated with ziprasidone and olanzapine in real-world use. Large, simple trials in psychiatry are a major way to examine the balance between benefit and harm in treatments as they're applied in clinical practice. And an increase in the QTc interval would be of clinical concern because it can induce ventricular arrhythmias that can result in sudden death. The ziprasidone observational study of cardiac outcomes, known as Zodiac, included more than 18,000 patients. The patients were from community mental health clinics, private psychiatric practices, residential care facilities, and academic treatment centers in 18 countries. They were assigned to ziprasidone or olanzapine in a random 1-to-1 fashion. Neither the physician nor the patient was blind to the treatment allocation, and they were free to change regimens and dosing. The participants included patients who were being newly treated for schizophrenia, in addition to those receiving continuing treatment. Each patient was followed for 1 year. In general, cardiovascular disease and risk factors were balanced across the 2 treatments. In addition to the primary outcome, non-suicide mortality, there were several secondary endpoints: sudden death, suicide, total mortality, cardiovascular mortality, hospitalization for any reason, and hospitalization for arrhythmia, diabetic ketoacidosis, or myocardial infarction. Discontinuation of randomized treatment was also recorded. Among the more than 18,000 patients, there were approximately 200 deaths during the follow-up year. There was no difference between ziprasidone and olanzapine with respect to non-suicide mortality. There was also no difference in total mortality, suicide, or sudden death. The findings for cardiovascular mortality varied according to the degree of certainty in the cause of death. One analysis included myocardial infarctions and arrhythmias that were judged to be the cause of death at a definite or possible level of certainty. With this definition of cardiovascular mortality, the risk from ziprasidone was actually lower than the risk from olanzapine. No cases of torsades or ventricular arrhythmia were observed. The two groups had similar rates of hospitalization for myocardial infarction, arrhythmia, and diabetic ketoacidosis. In addition, at the request of the FDA, a post-hoc analysis of all mortality events was conducted to determine the incidence of sudden cardiac death and all sudden death using ICD-10 codes. The results of these analyses were also consistent with those of the primary analyses. There was a difference between groups in the total rate of hospitalization. This was explained by a significant difference in the rate of hospitalization for psychiatric reasons, which was higher for the ziprasidone group. The proportion of patients who were still taking the assigned medication was lower for ziprasidone at 6 months and at 1 year. At the end of follow-up, approximately half of the patients assigned to ziprasidone were still taking it, but more than 60% of the olanzapine group were still taking that drug. For our final study, real-time electronic monitoring of patients with schizophrenia was devised to figure out whether using alcohol and non-prescribed drugs increases the risk of psychotic symptoms, or whether these substances are consumed as a way to alleviate symptoms or negative emotional states. Joel Swenson and colleagues gave PDAs to 145 patients with schizophrenia for recording symptoms and substance use as they occurred. The monitoring took place over 1 week. Each person was given a personal digital assistant and 45 minutes of training. They were shown how to operate the PDA and were given explanations of the questions and possible responses that would be presented by the PDA over the next week. 4 electronic interviews were administered each day, one during each of 4 3-hour periods between 9 a.m. and 9 p.m. The PDA interview included 6 questions about psychotic symptoms. 5 were about delusions related to being spied on, mind reading, thought insertion, thought broadcasting, and having special powers. The other question was about visual or auditory hallucinations. Each interview also asked the participants to use a 7-point scale to rate how sad they felt at that moment, and to use a separate scale to rate how anxious they felt. The effect of daily stressors was also evaluated. Participants were asked to select the event that had had the greatest impact on them since the last electronic interview, and then they were asked to rate how negative that effect was. At each interview, the participants were also asked if they had used alcohol or illicit substances during the time since the last interview. They were asked separately about each substance category: alcohol, cannabis, and other illicit substances. This last category included cocaine, methamphetamine, and other non-prescribed drugs. 3/4 of the patients reported taking their prescribed medication for the majority of the assessment days, but only 40% reported taking their medication every day during the week of the interview. Psychotic symptoms reported during the electronic interviews were associated with higher levels of concurrent sadness and anxiety and a more negative perception of events. For the overall category of all psychoactive substances, both sad mood and psychotic symptoms were significant risk factors for later substance use. Conversely, the use of any psychoactive substance was generally associated with an increase in anxiety and with a greater likelihood of the onset of psychotic symptoms. Psychotic symptoms were also a significant risk factor for the specific category of alcohol use. Prospective effects were also observed for anxious mood, which had a greater role in the continuation of alcohol use than in the onset. Alcohol use itself had no significant prospective effects on later psychotic symptoms, mood states, or perceived event negativity. This one-way pattern is consistent with a self-medication role for alcohol. The use of cannabis was more likely following anxious mood and perceived negative events, but it was less likely following sad mood. These predictors are partially consistent with self-medication, but the lower risk for sad mood may also reflect recreational use or specific social situations. Cannabis use was also linked to later decreases in the negative perception of events, but it was also related to strong increases in the risk of psychotic symptoms, both the onset of symptoms among patients who didn't report psychotic symptoms at baseline and the continuation of symptoms. This relationship has been reported previously, but the electronic monitoring provides stronger evidence of the directionality of the association. The use of other illicit substances was related to increased psychotic symptoms and increases in anxious mood. The use of prescribed medication did not influence the direction or significance of any of the observed associations. This concludes our audio highlights of the February issue of the American Journal of Psychiatry. Please visit our website, ajp.psychiatryonline.org, for the complete versions of these and other articles, including author affiliations and financial disclosures. We also welcome comments. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, we'll take a look at the effect of personality disorders on the course of depression, responses to emotional stimuli in the prefrontal cortex and amygdala of patients with schizophrenia, risperidone noncompliance and the return of positive symptoms in early schizophrenia, the use of genetics in treating alcohol dependence, and an update on copy number variants in schizophrenia. We hope that you'll join us. Thank you.